Hello, everyone, and we are very, very sorry for keeping you waiting. I hope you can hear us both well, and welcome to IVF webinar this time. We had small issues at the very beginning, but we are all set. Now it's all working. Please just let us know that you can hear us well. And I'm very happy to be here with Dr. Halyna Strelko. You can see her right here. Thanks so much for joining us. This is your first webinar with my IVF Answers, so we are happy that you decided to join this amazing initiative, of course, as well. And I'm very happy that we will be discussing tonight's topic, which is definitely an interesting one. Definitely a topic that brings lots of questions. And as always, remember that you will have time for the questions. You will just need to type those in the chat section. But first, we will start with Dr. Halyna's presentation. Dr. Halyna, how are you? Glad that you are with us tonight. And sorry that you also needed to wait, but sometimes it's just out of our hands. But I hope you are well.
Thank you very much. I am well. Thanks for all for the time, for patience, because okay, it was a little bit necessary to wait, but okay, now we can speak in, we can work in, we can answer all the questions. So exactly. My name is Dr. Halyna Strelko. This is my first presentation in this meeting. I am a doctor who are doing reproductive medicine since 1998. My first test was dedicated to polycystic ovarian syndrome. Second one was about poor ovarian reserve, so all possible problem. And today we will talking about late reproductive age. Now it is the most interesting topic, probably because most of our patients has in average 38, 39, 40 years old. It is average age of patients in our clinic. So hope you will see something interesting. I will be happy to answer all your questions. So don't hesitate. We will answer all questions at the end of my presentation. And now, please, we can start. So today we will talking about clinical case of my patients. She is my patient since, just a minute, I will open the presentation. Just sorry.
Dr. Halyna, can you see the presentation?
I cannot see. Sorry, I don't know how to do.
And let me just refresh. Hope now it's okay. Maybe take a minute, but it should be all working. I can see it. I believe patients can see it. So just wait a minute. It should appear.
Okay.
Okay. Can you see it? Because
yeah, I can see.
Okay, perfect.
Move, but it is not moving. Oh, like that. Okay, so this is my patient since 2009. Very nice girl. Okay, now she's 39 years old, but in 2009 she was young. But she has a lot of gynecological problem, polycystic ovarian syndrome. She comes to our clinic after 2 unsuccessful IVF treatment. First cycle was cancelled because on heavy OHSS syndrome. And second one was not so good as well because with mild stimulation, her doctor received very few number of eggs and embryo were arrested. So poor egg quality, teratozoospermia and polycystic ovarian reserve disease. So in 2009, we started the first IVF cycle with her. We have done a short agonist protocol, classic HCG triggering with low dose as well, because I afraid as well OHSS. And we received good number of eggs, 20 eggs, not very good quality of eggs, 15 was mature, only 2 blastocysts. It was fresh embryo transfer because in this period there was no good program of cryopreservation, and finally she delivered healthy boy. So after that, she's not from Ukraine. She returned to her country, and she has done a lot of IVF treatment. In 2013, Antagonist protocol, a lot of eggs, 40 oocytes, really big number, 8 embryos in total, and they were cryopreserved on day 3. In 2013, it was done cryotransfer with negative result. In 2015, 2-time cryotransfer as well, negative result. In 2016, new protocol, stimulation with urinary gonadotrophins, as well, very good response, 35 oocytes, 6 embryos, only 6 embryos, and also 72 hours, because on quality and probably embryologists afraid that it will not be go till blastocyst stage. In 2016-18 as well, 3 cryotransfers and no pregnancy, unfortunately. In 2019, new protocol, low dose of gonadotrophin, but anyway, OHSS syndrome and no blastocysts. So very, very bad protocol. In 2020, antagonist protocol, as well, poor embryo quality. Fresh embryo transfer, negative result. So quite difficult story. And 2021, she returned in our clinic. She moved her embryos in our clinic. She has 2 embryos frozen in 2015, 72 hours, but okay, it was slow freezing and not very good quality of embryos. We have done standard investigation. We have done even genetic test. Have seen antiphospholipid antibody, hormonal results, coagulation tests. All tests were more or less normal. Her IMH was quite high, 8.2. For her husband, infections were negative as well. We can see that her husband has a problem with morphology of spermatozoid, only 3% were normal, and also he has increased DNA fragmentation of sperm. So we discussed with her that, okay, cryotransfer of these 2 embryo, not so good quality with slow freezing, it is not very good option, because she has done till the moment 8 unsuccessful treatment, so probably necessary to create new embryos. Necessary try to achieve the better result, receive more eggs, better quality, try to avoid ovarian hyperstimulation syndrome, and also take attention on sperm selection methods. Also will be good to see if your embryos are normal or abnormal from genetical point of view, and probably doing cryotransfer in natural cycle, because with artificial cycle with replacement hormonal therapy, her endometrium does not react in well. Also, we decide to use growth hormone during the stimulation, because several scientific works showing that if we are using growth hormone, we receive better quality of eggs, better fertilization, better pregnancy rate, and live birth rate. So In this slide, you can see a lot of parameters which were studied, and we can see that really twice better result when we are using growth hormones, especially with advanced reproductive age. So her new protocol was like that. It was short antagonist protocol. We used Pergoveris. This is the FSH plus LH, because we know that in late reproductive age, normally sensitivity to LH is a little bit decreased, and ovary for normal steroidogenese need additional LH dose. And also we use Zomacton growth hormone for international unity. As triggering, we use differylin to prevent ovarian hyperstimulation syndrome. And finally, we receive a good number of eggs, 35 eggs. 20 was mature, not bad as well. But embryologists say that quality of eggs is very, very poor, very fragile eggs degenerate during denudation. And that's why we decide that part of these eggs we will do ICSI. It is written 9, but it is 19. But only 9 support well. And 11, it was IVF, standard classic IVF. And also we decide to do piezo activation of oocytes after ICSI. It means that there is special, not machine, but special device. We put eggs just after fertilization, and there is a increasement of electric, piezoelectric activity, and this permit to increase the concentration of ions of calcium inside of oocytes. And we know that this permit to oocytes to make fertilization and cleavage, because all these processes depending of calcium concentration inside of oocyte. And also our embryologist proposed to do the specific method of sperm selection and preparation, because as we remember, her husband has high DNA fragmentation, so we should select the best sperm cell without fragmentation, and like that improve the probability to have healthy embryo and healthy baby. And also embryologists use specific needle for ICSI procedure for fragile eggs. There is someone like that. And as a result, we receive 9 blastocysts in total after ICSI procedure. And unfortunately, we don't receive any blastocysts after IVF fertilization. We were really surprised, because, okay, eggs were fragile. We're afraid that we will not have result after ICSI, but it was just opposite, probably due to piezo activation of oocytes. So after ICSI, results were good. Total number of blastocysts is very good. And we decide the biopsy of trophectoderm of this 9 embryo. Not all go to NGS examination, only 5 best embryos, but we receive 3 euploid female embryos, and patients and me were very, very happy, because first baby was boy. And after we prepare her in natural cycle, it means that I give to her little stimulation, mild stimulation. When her dominant follicle reach 18 millimeter, we have done trigger with HCG, and after luteal phase were supported with 600 milligram of micronized progesterone. And two euploid embryo on days 7 after triggering were transferred, and we received positive result. Now she has progressive pregnancy, 8 weeks. So I hope all will finish very well. And now I would like that we discuss a little bit about the problem of late reproductive age and why our eggs became worse with the age. So we know the results of IVF treatment depends on age of patients, age of oocyte, if we can say like that, yeah. And we know that after 38, 40 years old, all over the world, in all country, in all clinic, we can see the decrease of pregnancy rate and decrease of live birth rate. Why this happened? There are some problems related on egg quality, and some of them not depend on egg quality, but anyway, they can decrease the probability of pregnancy and delivery. So depend on egg quality, it is mostly meiotic problem, abnormal fertilization, abnormal cleavage, also basic genetic abnormality of eggs, problem of eggs cytoplasm. With age of women, normally the number of mitochondria decrease dramatically. In 30 years old, in oocyte, we have around 250,000 mitochondria, but later, after 38 years old, it is more or less half of this number. Also, decreased ovarian reserve. So, it means that less eggs with the age. Normally, after 35, 37 years old, it is around 1% of the basic number of antral follicles. And also some problems not related to egg quality, like myoma, like endometriosis, like immune disease, general health problem like diabetes, and this also can decrease the probability of birth rate. About egg quality, it is not only nuclear problem. As we have mentioned, it is mitochondria number and functioning. Also, it may be shortening of telomere, and we know that number of cleavage of each cell depends on the structure of this end of chromosome, and when it became short, the division of cells became not possible. Also, spindle may be not normal organized. Some structure which organize spindle degenerate with age. So also it may increase the number of genetically abnormal eggs and embryos. We can say that not only eggs produce this genetic problem in embryo, paternal part may be till 20%. So also necessary to take attention about quality of sperm, sperm preparation, and some additional tests on sperm, because it may give around 20% of all genetical problem of embryo. For example, in some scientific works, we can see that with the age of husband, the sperm concentration, progressive motility, morphology decrease, and DNA fragmentation instead increase. And if we compare the percentage of DNA fragmentation and blastocyst formation rate and aneuploidy rate, we can see the close relation. Yeah? More DNA fragmentation we have, less blastocyst will have this clinical case. Yeah, less blastocyst we will have, and more aneuploid embryo we will receive. Yeah, for example, if the age of father is more than 50 years old, in average, DNA fragmentation is around 40% and around 75% of genetically abnormal embryos. When we compare the quality of eggs, it is our inner investigation study in our clinic. We have a big bank of donor oocyte, and as we have big data for that, we can compare donor oocyte and patient's oocyte in term on some morphological problem, and we can see that all morphological problem of oocytes increase with the age of woman. With donors' eggs, also we can have some morphological problem, but with the age, the number of this problem became more important. So when we study eggs of patients more than 38 years old, we found only 36% of morphologically normal oocytes. And if we have not big number of oocytes, sometimes we have no choice to have good oocyte, and that's why we have no choice and have no possibility to receive good quality embryo. Also, one of the problem which can be with the age of women, this is the problem of function of her immune system. Luteal phase should be very active and adequate to support normal pregnancy. And in late reproductive age, the function of immune system may have this functioning not correct. Because immune system is participate in formation of corpus luteum. This is the structure in ovary after ovulation which produce progesterone. So production of progesterone may be compromised. Progesterone regulate and induce the reduction of pro-inflammatory cytokines and increase the production of interleukin, and it help pregnancy to stay, to not go, to protect against spontaneous abortion. But if this mechanism is not working well, unfortunately, it may increase the number of spontaneous abortion. And this is, we can see with the age of women, that more often there is a problem of abortion. So, what we can do to improve the outcome? In our case, and in similar cases, we can use the specific sperm preparation, which we call microfluidic. This is avoid centrifugation and additional damage of DNA of sperm cell. And in this slide, you can see we compare the standard sperm selection method and standard sperm preparation method with this new method, which we call sperm chip. And we can see that in this case, with better selection and more gentle preparation, we found that fertilization rate is around 7% better. Blastulation rate is much higher with this method of preparation, and pregnancy rate is mostly 10% more. So it may be sometime in some case be very, very helpful, especially in case which we're discussing now. Also, piezoelectric oocyte activation. This is the method which permits to improve the concentration of calcium inside of oocytes, and it gives to oocytes more possibility to make normal fertilization, normal cleavage. And with piezo activation, we receive much better result in fertilization, in day 3 cleavage, and also in blastulation, especially in case on poor egg quality or late reproductive age. Also, we are doing morphological assessment of oocyte. We are looking for zona pellucida and detecting meiotic spindle, because if we destroy spindle during ICSI procedure, it will, of course, decrease the number of viable embryo. So, in case on difficult situation or poor egg quality, we detect meiotic spindle with specific microscope device, and it permits us to avoid this spindle destruction. We can see in this slide how it is looking. So each oocytes are observed before fertilization process, and the location of the spindle with specific camera is very helpful for further ICSI procedure. So, like resume of all this clinical case, I would like to say that decrease of pregnancy rate in advanced reproductive age depends not only on aneuploidy rate. Also, it depends on problem with spermatozoids, so need more deep examination of male partner. Also need specific strategy for stimulation, because more egg we receive, more possibility we will have to choose after good quality embryo. We can use artificial intelligence for embryo selection. Sometimes it may be very helpful because they analyze the thousands of different parameters. And in our clinic, we even comparing embryo selected by embryologists, very experienced embryologists, and by artificial intelligence, and we found big difference. Also, maybe helpful time-lapse technology, because it avoids to change temperature and CO2 concentration. We put fertilized egg inside of time-lapse incubator. We follow all stage of development, but not touch embryo till the moment of transfer or freezing. Very important is specific sperm selection method. Also, in all case of late reproductive age, we are doing artificial oocyte activation, and it is really very helpful. In some cases where we have not received before any blastocyst, we receive 5-6 good quality blastocyst. And we using also advanced EGTA methods and start to use non-invasive method. Like that, we don't touch embryo, don't take biopsy, and in some embryo with not very good developing trophectoderm, it may be also very helpful and improve probability of this embryo to implant. Thank you very much for your kind attention. I will be happy to answer all your questions.
Excellent. Thank you so much, Dr. Halyna, for that amazing presentation with lots and lots of detail. Definitely interesting case, a thorough. You taken this thoroughly, so explained. So thanks a lot. And yes, you are right. It is time for the questions. And as you can see, there are some questions right here ready. But of course, remember, if you have any left, you know what to do. Go ahead, type those in. And let's have a look. The first question has two parts of it. So let me just show you, okay? So here's the first part. I am 41 and currently doing embryo banking. Okay, embryo banking. I have frozen 2. Sorry, I will see here. Yeah, I have frozen 2 grade 1 embryos and I would like 1 or 2 more before I proceed with the transfer. What do you recommend in my case? Continue with freezing embryos until I would be 42 or try and implant the existing embryos? And if it doesn't work, use egg donor. My AMH is 3.59 picomoles.
Mhm. Okay, good question. Thank you very much. It is also always difficult to say about egg banking because, okay, when we are freezing eggs, embryo banking. Okay, it is different. So eggs were fertilized and finally embryo were frozen. Yeah. Yeah, with embryo, the problem that at 42 years old, there is a probability around 70, 80, 85% to have genetic abnormality of embryos. So if we are talking from this point of view, better to have 6, 7, 8 embryos and probably thinking about PGTA before transfer this embryo. As minimum, you will understand if your embryos are normal or abnormal. If you have not done that, as for me, better to freeze extra 2-3 embryos, and it will improve your probability to have as minimum 1 healthy and have pregnancy. Because, okay, if you start preparation, probably it will work and will not need to further treatment. But if not works, it will take time and you will repeat stimulation when you will have probably 43. So it is really difficult to say which way is the better because we don't know which will be the issue of your treatment. But as for me, probably will be better to freeze extra 1 or 2 embryos.
Thank you so much indeed for your very first question, detailed one as well. And of course, thanks so much for your help with that. Okay. Next question also from Christina. Let's have a look. So also, do you think that CoQ10, DHEA help with IVF success?
Mm-hmm. Yeah, thank you very much. You know, DHEA around 10 years ago was very, very popular as supplement for preparing women for IVF treatment. After that, there was a lot of publication where they say that there is no big difference, and they propose instead of DHEA, rather use transdermal testosterone, and it seems that it is working better. Coenzyme Q10, me personally, I prescribe a lot to my patients with low ovarian reserve. And also it seems that it can be helpful to improve the quality and increase a little bit the quantity. Publications say that it may be also helpful. Sometimes also may be helpful to take replacement hormonal therapy, low dose of estrogen and low dose of progesterone. It may sometime improve a little bit the ovarian reserve. So I think it may be helpful.
All right. Thanks so much for that advice and, of course, for your question, Christina. And, of course, there's a thank you from the patient for you right here. Thanks a lot. Okay, and well, let's have a look. There are more questions coming in. So this is an interesting one as well in regards to the presentation as well. Is PIEZZOELECTRIC, I think, activation expensive, or is it an affordable add-on cost? Is it a common method now within your clinic?
Thank you for your question. Yeah, it is not expensive. It is something like extra 60 or 70 euro. I don't remember the exact price, but it is something not very expensive. The price it is some kind of dish, specific dish, which we should buy instead of normal standard dish. We are using quite common in our clinic, especially for patients with low egg quality, for patients with previously not good fertilization, because in earlier work, scientific work were shown that this method it may improve fertilization rate. And after we have seen that it is improved not only fertilization but also blastulation rate, and using in situation when we has low blastocyst formation rate and bad decreased oocyte quality. So yeah, it is common in our clinic right now and not cost so much.
Excellent. Thanks so much, of course, for yet another question. One more. Is there any way to filter sperm to try and filter for gender? I heard some countries have such technology.
Look, there is no possibility to filter sperm for gender. There is some kind of how to say selection with some electricity, but also it is not 100%. It is like maybe 55 and 45, so it is not very exact. So if we discuss about gender selection, the best way is doing PGTA. In Ukraine, there is no restriction for gender selection. We don't do only gender selection, we are doing the full investigation of embryo for genetic disease, but it is not prohibit to say gender for the future parents.
Okay, thank you for the clarification for this as well. Okay, and one more question we've got. What are the chances of a frozen embryo successful at 42?
Thank you for your question. It is quite difficult to say because depends on quality mostly, and depends on genetic of this embryo. Because, okay, in average, statistics say that at 42 years old, around 80% of embryo are not genetically good. But individually, it is very different. Sometime in 42, we can receive 20 embryos, good quality, and half of them may be good and normal, and in this case, chances are absolutely good. But in some other cases, we can have only 1-2 eggs, not good quality, only one embryo with not good morphology. So in this case, chance is less than 5%. So necessary to see the exact situation to say the chance.
All right, thank you. And Sima has added one more question. So how do you prevent hypercoiling umbilical cord? Not sure here, sorry.
Probably I don't well understand this question.
I'm not sure what that is, hypercoiling. Perhaps, Sima, if you can give us some more details so we can try and...
Yeah, because
Exactly.
I'm
Yeah,
sure that I understand well this question.
of course, not a problem at all. Okay, and so Sima, if you can just please write a few things, maybe it will help us to help you out with this question. And right now I will go to the next question, okay? So, what are your thoughts on ovarian rejuvenation as a way to help egg quality and egg quantity?
Thank you for this question. It is the interesting new method which was introduced to improve the quantity and quality of eggs. There is a method when during laparoscopy taking part of ovary, then there is some specific solution and then put this back. And okay, in our clinic we don't do that. We are doing another method of rejuvenation, PRP therapy. Okay, it may works. In some cases, we receive better response in 2-3 months after this treatment. But in some case, I don't see very pronounced result and effect after PRP therapy. About classic method described by Japanese authors, we have no experience. According to the literature, it may work well, but better to do that before 42, 43 years old, because after, even with big number of eggs, we have not very good quality of eggs. And even if we receive 1, 2, 3 eggs, unfortunately, genetic of these eggs is not so good. So better to do all this method in before 42, 43 years old. Sometimes also we are doing the method as pronuclear transfer or spindle transfer. We can take nucleus of woman, put inside of donor oocyte, and like that we have, how to say, young cytoplasm with nucleus of patient. And also sometimes we receive much better results with this method, better egg and embryo, better embryo quality and better pregnancy rate.
Once more, thanks so much for the question. And of course, I will go back to the previous question because Sima has added some information. So here's her explanation. So hypercoiled umbilical cord. So I lost a baby at 8 months due to this condition.
Mhm.
Are you? I just checked this just to let you know. Yeah. So this is like the cord being too long or too short, not connecting well to the placenta, or getting knotted or squeezed. This is the
Okay,
information.
okay, I understand.
Yeah.
Look, unfortunately, there is no method of medical prevention of this condition. From the other hand, it is not the condition which will repeat. So if it was, it is rather like coincidence, like bad luck, if we can say like that. And anyway, there is no medical possibility to do something to prevent that. So I'm afraid that we are not able to do something and say that next pregnancy for sure we will not have this condition.
All right. Thanks so much, of course, for the explanation to this question indeed as well. And thanks for the follow-up. Yes, and that will we are able to answer. Okay, more questions are coming in. I see that someone is typing, and some other question from Fabiana is right here. I am 39, have high AMH for my age, 21.5 picomoles. However, my ovarian reserve didn't reflect my AMH. 9 eggs on the first cycle, 6 eggs on the second. One doctor suggested that I probably had PCOS when I was young, but I never had any symptoms. Even though my reserve is high, is it true that my egg quality might be low due to possible PCOS?
Very good question. About egg quality and PCOS. My first test was related to PCOS, and we calculate the probability of pregnancy in blastocyst received from PCOS woman and without PCOS, and it was the difference. Okay, it may be related, quality of eggs may be related to PCOS, but also PCOS is very, very different. In some cases, it is insulin resistance, obesity, diabetes, and all these conditions rise influence on egg maturation and egg quality than PCOS per se. Egg quality may be not very good without PCOS as well. In your case, probably there is some problem with receptors. So your body probably don't see very well FSH and LH hormones. And that's why with your high IMH level, you not give a lot of eggs during the stimulation. And probably the maturation of these eggs is not perfect. But okay, it is my suggestion. I cannot prove that, but probably this is one of the explanation. Another explanation, sorry, that maybe there is some cytoplasmic problem or some mitochondria problem. And also in this case, it is not specifically related to PCOS, but it may be that quality of embryos may be worse than we expect to have.
Thanks indeed for yet another explanation. Sorry, Fabiana added one more thing. Let me go straight to that. Yeah, it's a common. It makes sense because I had total fertilization failure on the first cycle. Thank you so much.
Mm-hmm.
Thank you indeed. Well, that might have been our final question, but I want to give you a minute. If you have any more questions, do it now. This is the final call for the questions. If not, we will be finishing slowly. But I would already like to thank everyone for joining us, for being patient. I know it took us a while to be able to be here tonight because we did have some issues, but I'm very happy that it was possible, and we are here. We were able to finish this webinar, and I'm glad that you were able to also ask your questions. I do believe you found it very useful. Dr. Halyna, it's been wonderful to have you. This is your first webinar with us. There were some issues.
Yeah.
Sometimes it's just out of our hands. But in the end, it worked. So that's the most important part, right? And is there anything else you would like to add before we finish?
Thank you very much for all who participate in this webinar. I'm really happy, and this is a big opportunity and big honor for me to be here with you. Thank you for your time. Hope it was helpful and interesting.
As you can see, Dr. Halyna, some thank yous coming up your way. Thank you for your presentation. Thanks so much indeed. And as you can see, it was a very interesting talk. Thank you so much for all the answers. So that means it definitely was useful. So again, thanks a lot. It has been recorded, everyone. So of course, you will have a chance to watch this. It will be available tomorrow on our website, myivfenses.com, but also on our YouTube channel. So I can only encourage you to have a look at the previous webinars. There are plenty of those on our YouTube channel, as you know. And I have also good news. Dr. Halyna is going to be back here next week on the 23rd of September, Thursday. So this is next week, right? So I do hope that you will be able to join us because we have more success stories. And Dr. Halyna next time will talk about low ovarian reserve, I believe, right? So it's going to be definitely, again, interesting, and you will be able to ask more questions next week. Okay? So enjoy your evening, everyone. Dr. Halyna, thank you so much. See you next week. And yeah, looking forward to it. Bye.
Good night. Bye-bye.
Bye.